Hi, everyone, and welcome to the presentation on opioid prescribing. This is going to be a presentation on the current Centers for Disease Control guidelines and practice management and ensuring that we're prescribing opioids safely as nurse practitioners. My name is Michael Bush. I am currently working on my doctorate degree in nursing through Saginaw Valley, and I recently graduated last August in 2016. So I'm fairly new to the practice. So hopefully my perspectives will kind of help guide you and inform you in terms of what you can expect going forward once you graduate. So let's get started here. Let's first talk about why prescriber education really is important. Um, there's clearly an opioid problem. How familiar you are with this depends on how connected you are with everything that's been going on within all 50 states. There was a letter from the Surgeon General on turning the tide on the opioid epidemic, which I'm actually going to read for you. And we'll talk about and discuss the pocket card outlining the most recent Centers for Disease Control guidelines. We're also going to be discussing the abuse and misuse and overdose of opioids in the country. And we're going to be talking about some new initiatives and guidelines, including the Comprehensive Addiction Recovery Act, which is also called CARA, which President Obama signed into law in 2016. We will also discuss the new CDC guideline for prescribing opioids for chronic pain and the stricter requirements for prescription drug monitoring programs, also known as PDMP use and prescription limits. So, there has been an incredible amount of activity at the state and federal levels, as well as in the medical and lay press recently, in an attempt to rein in the prescription opioid abuse, misuse, and overdose epidemic. So I'm actually going to read the letter from the Surgeon General on this that was released back in 2016. He says, I'm asking for your help to solve an urgent health crisis facing America, the opioid epidemic. Everywhere I travel, I see communities devastated by opioid overdoses. I meet families too ashamed to seek treatment for addiction. And I will never forget my own patient whose opioid use disorder began with a course of morphine after a routine procedure. It is important to recognize that we have arrived at this place on a path paved with good intentions. Nearly 2 decades ago, we were encouraged to be more aggressive about treating pain, often without enough training and support to do so safely. This coincided with a heavy marketing of opioids to doctors. Many of us were even taught incorrectly that opioids are not addictive when prescribed for legitimate pain. The results have been devastating. Since 1999, opioid overdose deaths have quadrupled, and opioid prescriptions have increased markedly, almost enough for every adult in America to have a bottle of pills. Yet the amount of pain reported by Americans has not changed. Now, nearly 2 million people in America have a prescription opioid use disorder, contributing to increased heroin use and the spread of HIV and hepatitis C. I know solving this problem will not be easy. We often struggle to balance reducing our patients' pain with increasing the risk of opioid addiction. But as clinicians, we have the unique power to help end this epidemic. As cynical as times may seem, the public still looks to our profession for hope during difficult moments. This is one of those times. That is why I'm asking you to pledge your commitment to turn the tide on opioid crisis. Please take the pledge at turnthetidrx.org. Together, we will build a national movement of clinicians to do 3 things. First, we will educate ourselves to treat pain safely and effectively. A good place to start is the enclosed pocket card with the CDC opioid prescribing guidelines. Second, we will screen our patients for opioid use disorder and provide or connect them with evidence-based treatment. Third, we can shape how the rest of the country sees addiction by talking about it and treating it as a chronic illness, not a moral failing. Years from now, I want us to look back and know that in the face of a crisis that threatened our nation, it was our profession that stepped up and led the way. I know we can succeed because healthcare is more than an occupation to us. It is a calling rooted in empathy, science, and service to humanity. These values unite us. They remain our greatest strength. Thank you for your leadership. And so this letter was actually sent to all the, the medical professions in the United States, including the primary care physicians, PAs, nurse practitioners. Um, so let's talk about how we actually got to this point. Really, kind of as a perfect storm. So from 1999 to 2014, more than 165,000 people have died from overdose related to prescription opioids. And in the chart to the right, you can see there's a trend with the males, which have kind of taken a sharp turn up in 2015. The females have kind of just steadily increased, and the total number of deaths is still increasing. So we talk about this critical seeding event. This happened back in December 1995 when the president of the American Pain Society came forward to a whole group and addressed that. He said the pain is going to be basically the fifth vital sign, and we need to be addressing it at each visit. We need to be addressing it in the hospitals, and from there, this has kind of just spiraled. In primary care, acute pain is a symptom of greater than 80% of the provider visits, and chronic pain affects over 75 million patients at any given time. There's four primary vital signs, which are the objective, the heart rate, the temp, the blood pressure, pulse, those things. But pain is uniquely subjective, so we don't really have a great way of gauging pain yet. And this, again, is one of the problems here. So we talk about this perfect storm here with the Food and Drug Administration. They came out in 1995 and approved OxyContin, which is an extended release formulation of oxycodone. Um, so it was the first formulation of oxycodone that allowed dosing every 12 hours instead of every 4 to 6. And this new product offered fewer pills and better round the clock analgesic benefits like all the extended release and long acting opioids do. Unfortunately, this was a classic case where a manufacturer misled medical providers, patients, and even the FDA for almost about a decade about the addictive properties of OxyContin. They even misbranded the product as abuse resistant as opposed to tamper resistant. Delineation of terms were much more adamant about these days. The spiel was that OxyContin, partly due to its slower onset, had a low risk addiction, meaning you didn't get the dopamine surge compared to other immediate release opioids. So we came up with the COX-2 inhibitors in 1998. Great idea. Um, and then the non-steroidal anti-inflammatories, which directly target cyclooxygenase 2, an enzyme responsible for inflammation and pain. They said, cause fewer gastrointestinal side effects. And then Viex was pulled from the market in 2004 for increased cardiovascular risk. So initially, the concept was developed that COX-1 functions as a housekeeping enzyme, whereas COX-2 yields prostaglandins involved in the pathophysiological reaction, such as inflammation. In the gastrointestinal tract, the maintenance of mucosal integrity was attributed exclusively to COX-1 without a contribution of COX-2, and the ulcerogenic effects of the nonsteroidal anti-inflammatory drugs were believed to be the consequence of inhibition of COX-1. Recent findings, however, indicate that both COX-1 and COX-2, either alone or in concert, contribute to gastric mucosal defense. So we must remember an important function of COX-2 is the acceleration of ulcer healing. COX-2 is upregulated in a chronic gastric ulcers, and inhibitors of COX-2 impair the healing of ulcers to the same extent as non-selective NSAIDs. So taken together, these observations show that both COX enzymes are essential factors in mucosal defense with specific contributions in various physiological and pathophysiological situations. Lo and behold, the FDA comes out with a black box warning not just for the COX-2 inhibitors, but all NSAIDs may increase the risk of serious cardiovascular thromboembolic events, myocardial infarction, and stroke, which can be fatal. This may increase with duration of use in patients with cardiovascular disease, or risk factors for cardiovascular disease may be at greater risk. So now we've created a situation where in 1995 we're starting to assess pain, and now we're saying in 2004 we basically can't use NSAIDs anymore. So we've skipped the whole step one of the World Health Organization pyramid of how we increase our use of pain medications. We've gone straight from basically using NSAIDs or Tylenol and adjunctive medications to weak opioids. So you can see the paradox there. There was a sincere effort in 2012 to start reducing opioid prescriptions, which you can see here. And it has been successful and has continued to decline. I don't have the most recent data, but you can see it went from about 219 million prescriptions in 2011 down to 207 million prescriptions. So these trends are partially due to prescribers changing their standards in terms of um, who gets these prescriptions. And then we look at the fact there's fewer scripts out there for diversion or non-medical use. So unfortunately, the deaths involving opioids still continues to rise at quite a significant level. If you look at the green line, it shows you basically any opioid, and this is per 100,000 population, about 10.5. Heroin use has skyrocketed since the year 2010. And then the other synthetic opioids such as street fentanyl, tramadol, those other ones, um, also continues basically to kind of skyrocket. So if we look at morphine, we have the equivalent of 10,000 micrograms or 10 milligrams. Fentanyl, to get the same effect, requires only 100 micrograms. And carfentanil, which is frequently used as a elephant tranquilizer, basically takes 1 microgram. And you're seeing kind of a mixture of all three of these drugs on the street now. So we need to be aware that up to 1 in 4 patients receiving opioids for long-term or opioids long-term in primary care for non-cancer pain struggles with addiction. So potentially 25% of your patients who are on chronic opioids for their pain actually struggle with addiction. So that needs to be a number that kind of sticks in your head, and you have to kind of be able to pull out these patients and say, could this possibly be someone that we need to be looking at more closely in terms of getting them the help that they need? About 1,000 people seek emergency department care for misusing prescription opioids each day, and up to 75 people die. The leveling off of prescriptions in 2012 was just that, as overdose and addiction continue to be a huge issue. And factors for the rising death and addiction from opioids include continuing misuse and abuse of prescription opioids, migration of former patients to the streets for heroin, and increasing availability of fentanyl and other synthetics. So, in this slide, we can see that for the people who have been on long term opioids at either 36 milligrams or less, um, 120 morphine milligram equivalents, or 120 morphine milligram equivalents, the abuse potential for opioid use disorder is significantly higher for the people who are on the high dose opioids, um, especially over the 120 there. Interestingly, 4 to 5 heroin users have previously used painkillers. Whether the previous use of painkillers led them to heroin use wasn't really discussed in this study. So there's a quote from a um, pain management physician. He said, "I see a huge chill on opioid prescribing, followed by a massive increase in heroin deaths. Addiction care needs to be funded before the storm. Things are going to get way worse before they get better." So, the Substance Abuse and Mental Health Services Administration estimate from 2014 suggests that there were approximately 2 million individuals in the United States who suffered from prescription opioid abuse and dependence. Those numbers may be higher as of now. Also, estimates of the number of individuals suffering from heroin addiction range from as low as 450,000 to over 580,000. So, uh, one of the new legislations that was set forth last year by President Obama is called the Comprehensive Addiction and Recovery Act. So, this was a bipartisan bill containing many interventions designed to turn the tide on the opioid and heroin crisis, providing these interventions are funded by Congress. CARA seeks to expand prevention and educational efforts, particularly aimed at teens, parents, and other caretakers, and aging populations to prevent the abuse of methamphetamines, opioids, and heroin, and to promote treatment and recovery. Number two, it looks to expand the availability of naloxone to law enforcement agencies and other first responders to help in the reversal of overdoses to save lives. Number three, it looks to expand resources to identify and treat incarcerated individuals suffering from addiction disorders promptly by collaborating with criminal justice stakeholders and by providing evidence based treatment. Number four, it seeks to expand disposal sites for unwanted prescription medications to keep them out of the hands of our children and adolescents. Number five, it seeks to launch an evidence based opioid and heroin treatment and intervention program to expand best practices throughout the country. Number six, seven, strengthen the prescription drug monitoring program to help states monitor and track prescription drug diversion, help at risk individuals assess services. It also looks to launch a medication assisted treatment and intervention demonstration program. And it also allows nurse practitioners and physician assistants who meet certain specified education and training requirements to prescribe uh, buprenorphine, which is Suboxone, to treat opioid addiction. Unfortunately, there isn't widespread agreement on how to find the $900 million program. Many individual states are actually undertaking programs to help implement the aforementioned changes, and if funding does eventually get approved, it will just help to bolster the states in their initiatives and programs further. So let's talk about the CDC guidelines for prescribing opioids for chronic pain. In March of 2016, the CDC released recommendations for providers who prescribe opioid analgesics. This is the first time a federal agency has issued prescribing directives. Even though their guidelines are for chronic pain, we know long term opioid use often begins with the treatment for acute pain. And when opioids are used for acute pain, clinicians should prescribe the lowest effective dose of immediate release or IR opioids for the shortest therapeutic duration. Prescribers should voluntarily limit their first prescription for acute pain to about a 3-day supply. And this is becoming more common practice in the hospitals, providers' offices, dentist offices, etc. Very rarely, prescriptions for over 7 days are needed. Some states, including New York, Rhode Island, Connecticut, and some others, have adopted legislation limiting opioid prescriptions to 7 days for acute pain. Pharmaceutical companies who manufacture opioids are mobilizing and kind of quietly trying to quash all of this legislation, uh, obviously. So, 26 states require all prescribers who are registered as dispensers to register to use the prescription drug monitoring program. And Michigan isn't necessarily one of them, although we have moved pretty much to a new PDMP program just in the last um, 3 to 6 months, and it's much more convenient and easy to access than the previous um, prescription drug monitoring program was. So there are 16 states in yellow which are required to check PDMP data before prescribing opioids or other control medications. Michigan is not one of those, as you can see. And with Kentucky here, the first, it was basically in 2012, Kentucky became the first state to require providers to check the PDMP data before prescribing opioid or other control medications. Since the law was passed, our overdose related hospitalizations have dropped 26%, and prescription opioid deaths have dropped 25%. And this was the first reduction in about nearly a decade. PDMP use leads to increased referral to addiction and treatment programs as more providers refer patients for treatment after discovering patients are taking painkillers or other scheduled drugs from multiple sources. This was a quote by John Eady. He was a former director of the PDMP Center for Excellence at Brandeis University. He said comprehensive mandates are the single most effective thing that states have done to curb opioid prescribing, and it seems to have an almost instantaneous effect. So, this is substantial when it comes to why we should be running these PDMP reports. Regarding the new CDC opioid guidelines, while many states have undertaken or taken an active role by placing limits on opioid prescriptions for acute pain, the newer CDC guidelines are really intended for primary care clinicians treating patients with chronic pain. So, chronic pain is defined as pain lasting greater than 3 months or past the time of normal tissue healing. The CDC guidelines, the main objectives are to improve the understanding and communication about the benefits and risks of opioids for chronic pain between clinicians and patients, to improve the safety and effectiveness of pain treatment, and to reduce the risks of long term opioid therapy. It's really intended to inform clinicians who are considering prescribing opioid pain medication for painful conditions that can or have become chronic. So, we talk about the high risk prescribing practices in terms of high dose prescribing, overlapping opioid and benzodiazepine prescriptions, and the use of extended release or long acting opioids for acute pain, and as needed dosing for breakthrough pain. Those are very high risk practices that, as a nurse practitioner, you really need to try to avoid. Here's a very important piece of information for you to recognize and to share with your patients. Clinical data has provided no evidence of a long-term benefit of opioids for pain and function versus no opioids for chronic pain. And these outcomes were analyzed over the course of about a year, so it was a short-term study, but at the same time came up with pretty conclusive results. Extensive evidence suggests some benefits of non-pharmacological treatments and non-opioid medications compare with long-term opioid therapy along with less harm. The CDC recommendations are divided into three major headings. It's determining, number one is determining when to start opioids or continue them for chronic pain. Number two, opioid selection, dosage, duration, follow-up, and discontinuation. And number three, assessing the risk and addressing the harms of opioid use. So let's talk about the first point, which is determining when to start opioids or continue them for chronic pain. This would be when we have used the non-pharmacological therapy, the non-opioid analgesics such as NSAID, coxswain, acetaminophen, adjunctive medications such as antidepressants, the selective norepinephrine reuptake inhibitors, or the tricyclics, some anti-epileptics such as gabapentin and others. We need to consider opioid therapy only if expected benefits for both pain and function are anticipated to outweigh the risks to the patient. And if opioids are used, you need to combine them with non pharmacological therapy and non opioid medications as appropriate. We also need to be establishing realistic treatment goals for pain and function with our patients and consider how therapy is going to be discontinued if the benefits do not outweigh the risks. When to continue opioid therapy, basically, if there is clinically meaningful improvement in pain and function, which outweighs the risks to the patient's safety. And before starting and periodically during opioid therapy, you need to discuss known risks and realistic benefits of the opioid therapy, as well as patient and clinician responsibilities for managing this type of therapy. And this is on the right, the World Health Organization kind of stepwise fashion and how to start treating chronic pain. For the second point, which is opioid selection, dosage, duration, follow-up, and discontinuation. When starting any opioid therapy for chronic pain, we need to be prescribing immediate release opioids instead of the extended release or long-acting opioids. Extended release and long-acting opioids are inherently more dangerous. Initiating with immediate release opioids should always be considered what you can call a trial. And will they be effective for and tolerated by the patient is kind of something you both need to sit down and discuss. You need to start by prescribing the lowest effective dosage and use caution when prescribing opioids at any dosage. You need to reassess the evidence of benefits and risks when increasing the dosage to greater than or equal to 50 morphine milligram equivalents per day. And avoid increasing dosages to greater than or equal to 90 morphine milligram equivalents per day, or you need to carefully be justifying why you're doing that. You also need to evaluate the benefits and risks with the patients within 1 to 4 weeks of starting opioids for chronic pain or of dose escalation, and reevaluate continued therapy with patients every 3 months or more frequently. Basically, you need to reevaluate monthly with Schedule 2s. And if the benefits do not outweigh the harms, you need to optimize other therapies and taper opioids to the lower dosages or discontinue them altogether. For the third point, which is assessing risk and addressing the harms of opioid use. So, before and periodically during opioid therapy, you need to be evaluating the risk of opioid related harms. You need to incorporate strategies to mitigate risk, including offshoring or offering naloxone when increased risk for overdose exists. Um, you need to look at their history, any history of overdose, any history of substance use disorder, or any history of dosages greater than or equal to 50 morphine milligram equivalent per day, or concurrent benzodiazepine use. You need to be reviewing the patient's history of controlled substance prescriptions using the PDMPs. You need to review PDMP data when starting opioid therapy for chronic pain and periodically during opioid therapy for chronic pain, ranging from every prescription that you write up to every 3 months. Urine drug screening before starting opioid therapy, and you need to consider urine drug testing at least annually to assess for prescribed medications as well as other controlled prescription drugs and illicit drugs. Consider doing random urine drug screens on all patients throughout opioid therapy, and whenever possible, avoid prescribing opioid pain medications and benzodiazepines concurrently. When concurrent prescribing is necessary and warranted, you need to be monitoring the patients with greater diligence and consider recommending naloxone for an emergency. You need to be aware of the signs and behaviors suggestive of opioid use disorder, and you need to offer and arrange for evidence-based treatment, which is usually medication-assisted treatment with buprenorphine or methadone in a combination with behavioral therapies for patients with opioid use disorder. So before prescribing, they do recommend, and this will be on the little handout card, um, you need to be using a validated pain scale, and the CDC recommends a PEG pain scale, which is basically a series of 3 questions. The first question is from 0 to 10, what number from 0 to 10 best describes your pain in the past week, 10 being the worst. And then number 2 is what number from 0 to 10 describes how during the past week pain has interfered with your enjoyment of life. So does it not interfere with your enjoyment of life, or does it completely interfere with your enjoyment of life? And number 3, what number from 0 to 10 describes how during the past week pain has interfered with your general activity. So does it not, not affect your general activity at all, or does it just completely interfere with your general activity? Also, another point that the CDC recommends is pain management agreements. They stay away from the word contracts because that kind of puts you in a problem if you were ever to be called to a court of law regarding that, where it's not really a contract, it's an agreement. This is just an example of one. There's several out there. But basically, it outlines you're going to take the medication at a certain time each day. You're going to take it as prescribed. You're only going to fill one prescription, per month from the same provider. You're not going to go to the emergency department and fill other prescriptions for the same medication at the same dose or lower dose or higher dose. You're going to use the same pharmacy every time you fill that prescription. And you're not going to, if you test positive uh, for other substances, you basically are going to give up your right to that contract and that medication that you're receiving. So if we quickly discuss the 50 morphine milligram equivalent and the 90 morphine milligram equivalent, 50 milligram of hydrocodone, which is like 10 tablets of the 5-325 Norco that we typically prescribe, that would be a pretty significant dose in and of itself. And then 33 milligrams of oxycodone, which is about 2 tablets of the oxycodone sustained release, 15 milligrams. That gives us about 50 morphine milligram equivalents per day. And then 90, you basically see you can take 18 tablets of Norco per day, or up to 4 tablets of the sustained release 15 milligram oxycodone. So we'll talk just a brief minute about naloxone, which is also Narcan. in the United States, which naloxone, sold under the brand name Narcan, among others, is a pure opioid antagonist that can displace opioids agonists like morphine, oxycodone, hydrocodone, and the like from receptor sites, and thus reverse acute opioid induced respiratory depression. It is a legal drug, it has no abuse potential, and has been approved by the FDA for intramuscular, and in the year 2015 was approved for intranasal routes. The CDC, AMA, and the American Society of Addiction Medicine, or ASAM, have all recommended prescribing naloxone along with opioid prescriptions when factors that increase the risk are present. So it does typically work within 2 minutes when given intravenously and within 5 minutes when used intramuscularly. There are 47 states where naloxone is available. Michigan is one of those states. And 37 states provide criminal immunity to prescribers who provide, dispense, or distribute naloxone. And it's good that Michigan is one of those states as well. So you really can't get in trouble. So we look at the sales of naloxone here, and they've just basically skyrocketed, and actually in 2016 continued to rise even further, which is good in a couple of respects. That we may be able to save some lives with this drug, but there are some downsides to this too, in terms of rising cost of this medication for people who may not have insurance. Or number two, that the addicts say, well, basically, I can keep doing what I'm doing without any consequence because somebody's going to be there to hopefully save my life. So let's talk briefly in terms of a case study. This was actually a patient I saw fairly recently. He was a 70-year-old male who presented to my office to establish care with a new provider. He had a history of chronic pain secondary to osteoarthritis, mostly in his knees and his back, some hypertension, coronary artery disease, insomnia, and he was fairly obese. He had been in a lot of pain because he hadn't been able to get his refills from the previous provider, whose DEA license had been suspended, so he came to us. And we run the maps, and here's what we find. So he had been filling, this is exactly what maps look like. This is a real maps. Um, all the patient identifiers have obviously been removed, but we look at when he fills these medications. Let's first go over some of the medications he was taking. The Ambien, 10 milligrams. Um, he was getting a 30-day supply of that. We look at the Norco 7.5 325s. He's taking about 3 of those a day, and filling them quite regularly. He was also on phentermine, which is Adipex, which is a weight loss drug. And granted, he's 70 years old. And his justification to me was, well, it's just something to help with my appetite. And what you don't see on here is if you scroll back to late 2016, he was also being prescribed fairly high doses of Soma, which is a muscle relaxer, which really isn't even prescribed by fairly anyone these days. So there's about four drugs that he was taking pretty regularly. All of them have abuse potential. And given the patient's advanced age, you say, well, what do I do? What do I do with this guy? So it's really a difficult discussion to sit down and have with these patients. And this is, I work at a federally qualified health center. This is the type of patient that we see day in and day out. The people who have basically been somewhat dumped on us because either their physicians have lost their licenses or um, their circumstances have changed. But conveniently, one policy our clinic has is that we don't fill any narcotic prescriptions, really, or controlled prescriptions on the first visit, regardless of their past circumstance. So it's important to address the ease on multiple scheduled medications which all kind of pose an inherent risk when taken individually, let alone when you take all of those medications together, combined. Um, so, what are his alternative choices to opioids? And I did sit down with him and discuss this. He, um, not in this gentleman's case, but in any other case, you could probably say NSAIDs, heat or ice, duloxetine, acetaminophen, pregabalin, or any topical medications. And there are a lot of compounding pharmacies out there, but Healthway is probably the number one that I would recommend. Um, all of these are alternatives for this gentleman, except in his case, I really couldn't give him NSAIDs because he had an incomplete Shotsky's ring and some other gastric problems. So we would also want to consider physical therapy, transcutaneous nerve stimulation, cognitive and behavioral therapy, rehabilitation, progressive muscle relaxation, psychotherapy, massage, acupuncture, acupressure, exercise therapy, or lifestyle changes for this gentleman. And I guess just going back to this slide, he was okay with the fact. I think he understood that I wasn't going to continue these medications for him. And I don't see a good reason why he would be on the Norco and some of those other control medications when there are other alternatives out there. So that's kind of the takeaway is no matter what patient you see, if they've been on long-term opioids and you really can't justify it, just based on what they're telling you, it's go with you have to go with your gut. So as we look forward, this was um, a quote from Dr. Andrew Colandy. He said, "The root cause of our nation's opioid epidemic is not unethical or illegal medical practice, but a combination of factors including lack of sufficient patient interaction time, concern over patient satisfaction surveys, pharmaceutical marketing, unrealistic patient expectations, non objective pain rating scales, and the well intentioned yet tragically misguided practice of overprescribing opioids for common conditions." And so that really sums up this whole presentation because it's not necessarily any particular person's fault for what is happening in the country. And I think we are definitely headed in the right direction in terms of the opioid prescribing practices. As nurse practitioners, I think we have that gut instinct to decide who really needs to be continued on some of these chronic pain medications. And I'm not going to get into the um, prescribing of immediate or of long acting or extended release opioids. That would be a whole module and different training that you would have to